Welcome to the Anesthesia and Perioperative Medicine channel. Today, we are going to tackle one of the most complex and, let's be honest, intimidating challenges in our field, the anesthetic management of adult patients with Fontan Physiology. As these incredible patients are living longer and longer, they're showing up on our OR schedules more frequently for all kinds of non-cardiac surgery. That means a deep, practical understanding of their unique circulation isn't just academic anymore. It's absolutely essential for keeping them safe.
So, what's our game plan for today? Here's the roadmap. We're going to start by building a really solid foundation, getting the physiology down cold. Then, we'll look at the ripple effects, the long-term consequences this circulation has on the entire body. From there, we'll jump into the real world and break down 3 fascinating and challenging cases. And finally, we'll pull it all together into a clear, actionable standard operating procedure that you can use in your own practice.
All right, first things first. Before we can even think about managing these patients, we have to understand the why. Why does the Fontan circulation even exist? It's not just a simple patch job. It is a fundamental replumbing of the entire circulatory system, an ingenious solution born out of a life-threatening necessity. So the whole journey starts with his core, devastating problem. A patient is born with what is effectively half a heart. Whether it's hypoplastic left heart syndrome, tricuspid atresia, or some other complex defect, the bottom line is the same. You're missing a ventricle. There's no way to create that beautiful, efficient, parallel circulation with one pump for the lungs and one for the body. It's just not in the card.
So what do? Well, surgeons devised this absolutely remarkable 3-stage surgical journey, typically performed over the first few years of a child's life. Think of it like a 3-act play. Act 1, like the Norwood procedure, is all about immediate survival, making sure the body gets blood flow and the lungs don't get flooded. Act 2, the bidirectional Glenn, is a massive step. It reroutes all the blue blood from the upper body to flow directly into the lungs. And then, the grand finale, Act 3, is the Fontan procedure itself. This is where they connect the blood flow from the lower body to the pulmonary arteries, completing this incredible new circuit.
And this, right here, leads us to the single most important concept you have to burn into your brain. In a completed Fontan circulation, there is no right ventricle in the circuit. It's gone. So how on earth does blood get through the lungs? The answer is passively. It just flows. It's a non-pulsatile, low-pressure flow driven entirely by the central venous pressure being higher than the pressure in the left atrium. That's it. That's the engine.
This diagram just lays it all out so perfectly. Look at the top. That's the normal, elegant system we all know and love. 2 pumps working in parallel. Easy. Now look at the bottom. That is the Fontan. That one single ventricle has to do everything. It has to generate enough force to push blood through the systemic circulation, then through the Fontan connection itself, and then through the pulmonary vascular bed, all in one continuous loop. The entire energy for the whole system comes from that one heroic chamber. Okay, so for this incredibly delicate system to even have a chance of working, 4 things have to be in perfect balance. I call them the 4 pillars of Fontan. If you knock one of them over, the whole thing can come crashing down. You need adequate preload. That systemic venous pressure has to be high enough to push blood through the lungs. You need ridiculously low pulmonary vascular resistance. You need a good, competent AV valve. And of course, that single ventricle has to be a strong, healthy pump. Mess with any of these, and you're in trouble.
This table really puts it all in black and white, doesn't it? Let's just walk through it. Pumping chambers, 2 versus 1. Pulmonary blood flow, active and pulsing versus passive and lazy. But look at this one, central venous pressure. Normally it's less than 5. In a Fontan, it's designed to be chronically high, somewhere between 10 and 15, because that's the only way to drive flow. And this leads to the next point, cardiac output reserve. There is none. It's basically fixed. You can't just give a fluid bolus and expect the cardiac output to jump up. The whole system has been rewired from parallel to serial.
So we've established this new circulation, which is a life-saving miracle. But, and this is a huge but, it comes at a price. This is not a cure. That chronically high venous pressure, the very thing that makes the system work, becomes the root of almost all the long-term, multi-system problems that these patients develop over a lifetime.
Let's start with the heart itself. It's under constant siege. You've got surgical scars. The atria are stretched out like old balloons from decades of back pressure. All of this creates a perfect storm for electrical chaos. Atrial tachyarrhythmias are incredibly common. We're talking up to 45% of patients, and these are devastating because in a system with a fixed cardiac output that depends on that atrial kick for filling, a fast rhythm can lead to hemodynamic collapse in a heartbeat.
Now think about the flow dynamics. Instead of a strong, pulsatile flow, you have this slow, sluggish river of blood meandering through the Fontan pathway. That, combined with arrhythmias and a generally hypercoagulable state, makes the whole circuit a breeding ground for clots. The risk of thromboembolism is a constant shadow hanging over these patients, which is why almost every single one of them is on lifelong anticoagulation, a huge factor for us in the perioperative world.
This next one is a big one, and it's pretty much unavoidable. Fontan-associated liver disease, or FALD. Just picture the anatomy. The liver is sitting right there, downstream from the IVC, taking the full force of that high venous pressure day in and day out for decades. It's like a sponge that never gets wrung out. This chronic congestion leads to inflammation, fibrosis, and eventually a unique form of cirrhosis, which unfortunately carries a very real risk of liver cancer. And the damage doesn't stop there. This high venous pressure messes with just about everything. The gut can get so congested it starts leaking massive amounts of protein. The lymphatics can go haywire, causing this bizarre and terrible condition called plastic bronchitis. The kidneys take a beating from the combination of low cardiac output and high venous pressure. And even the lungs themselves can become stiff and restrictive over time.
All right, enough theory. Let's see how this all plays out in the real world, in the operating room. Our first case is a 34-year-old man with a complex Fontan, and he's coming to us for an EP study and catheter ablation to get rid of a stubborn atrial tachycardia. Right away, you know this is going to be a high-stakes anesthetic. Okay, so rule number one when you get one of these cases is you have to become a detective. There is no such thing as a standard Fontan. You have to dig into their records and understand their specific plumbing. Look at this guy's anatomy. He's got dextrocardia, situs inversus, and a complex lateral tunnel Fontan with 2 SVCs. You absolutely have to know the map of the territory before you even start the journey. So let's watch the play-by-play from the anesthetic record. Induction with etomidate and fentanyl is stable, but then at T plus 30 minutes, the EP team induces the arrhythmia on purpose to map it. And bam, you see the blood pressure dip and the PAP start to climb. They need milrinone and norepinephrine just to hold steady. But the real drama starts at T plus 90. During ablation, he flips into this crazy fast tachycardia at 200 beats per minute. And look at those numbers. The systolic plummets to 82 and the PAP nearly doubles, shooting up to 29. The TEE shows a massive shunt, the whole system is crashing, and they have to abort. This is a perfect, terrifying illustration of how poorly they tolerate arrhythmias. All right, on to our next couple of cases. These are great because they highlight two very different but equally critical challenges: what to do in an emergency trauma situation and how to manage the absolute minefield that is laparoscopic surgery. So here's the scene. A 27-year-old with a Fontan takes a nasty spill on an e-bike and just shatters his arm. He needs emergency surgery. The number one question for the anesthesiologist is, what is your anesthetic plan? Because in this case, the choice of anesthetic itself is probably the most important decision you're going to make.
And the team made the absolute best call. They performed a supraclavicular brachial plexus block. Just look at this breakdown of why that was so brilliant. With one elegant injection, they dodged so many bullets. They avoided any myocardial depression from our anesthetic agents. They completely sidestepped the dangerous rise in PVR that you get from positive pressure ventilation. The patient kept breathing on his own, which is fantastic for promoting venous return. It was a huge win. Regional anesthesia is so often the safer, smarter choice for these patients.
Okay, get ready, because now we're entering the final boss level of Fontan anesthesia, laparoscopy. Seriously, if you were to design a procedure specifically to destroy a Fontan circulation, it would look a lot like this. We've got a 38-year-old man, he's got the expected FALD, and now he's got liver cancer that requires a laparoscopic resection. This is about as high risk as it gets.
So why is this so terrifying? Because pneumoperitoneum attacks the Fontan from every conceivable angle. It's a forefront war. First, you're pumping gas into the abdomen, which physically squeezes the IVC and cuts off your preload. Second, that pressure pushes up on the diaphragm, increasing intrathoracic pressure and also cutting off preload. Third, the CO2 gets absorbed, causing hypercarbia and acidosis, which are both potent pulmonary vasoconstrictors. And fourth, you're running the risk of a catastrophic gas embolism. Literally every single aspect of it is hostile to this physiology.
So how did they pull this off? With an aggressive, proactive, full-court press. The second they started insufflation, even at a low pressure of 8 millimeters of mercury, the CVP shot through the roof to 31. The team didn't wait. They immediately hit it with a triple drug cocktail: nitroglycerin to reduce the CVP, milrinone to support the ventricle and vasodilate the lungs, and inhaled nitric oxide to selectively blast open the pulmonary vessels. And look at the result. They wrestled that CVP back down to 22 and held the line, maintaining a stable cardiac index. Just a beautiful example of proactive, intelligent anesthesia.
Okay, we've seen the physiology, we've seen the long-term problems, and we've seen it all play out in the OR. So let's put it all together. How do we build a repeatable, safe game plan for these patients? We're going to build a standard operating procedure, starting with what you do before the patient even rolls into the room.
These are the 5 commandments of Fontan anesthesia. You have to burn these into your mind. Number 1, preload is king. They are exquisitely dependent on it. Number 2, they are highly sensitive to afterload. Number 3, PVR is the ultimate villain. Any increase is bad news. Number 4, their cardiac output is what it is. It's relatively fixed. And number 5, the risk of blood clots is always there. Every single decision you make has to be filtered through these 5 principles. So, your preoperative assessment has to be a meticulous, head-to-toe, deep dive. It's not optional. You have to go system by system. Cardiac, what's the ventricle doing? Are there arrhythmias? Pulmonary, how stiff are the lungs? Hepatic, how bad is the FALD? Do they have cirrhosis? Can they even metabolize your drugs? You have to check renal function. You have to manage their anticoagulation carefully. You are going to find end organ dysfunction. Your job is to find it and plan for it before it surprises you in the operating room.
And let me be absolutely crystal clear on this point. You are not a lone wolf. Trying to manage a Fontan patient by yourself is not brave, it's reckless. You must get on the phone. Talk to their cardiologist, talk to the surgeon, talk to the ICU team that will be taking care of them afterwards. A pre-procedure huddle isn't just a nice idea, it is the absolute standard of care, period.
All right, it's game day. The patient is rolling into your operating room. All of that careful planning was just the warm-up. Now, it's all about meticulous execution, constant vigilance, and staying 3 steps ahead of their very fragile physiology.
So what are your prime directives in the OR? Your absolute commandments. Number 1, maintain preload at all costs. Don't let them get dry. Number 2, minimize PVR. You have to aggressively hunt down and eliminate its 5 great enemies: hypoxia, hypercarbia, acidosis, hypothermia, and high airway pressures. Number 3, worship sinus rhythm. An arrhythmia is a crisis waiting to happen. And number 4, fear the bubble. Be absolutely paranoid about de-airing your IV lines every single time.
Let's talk about your drug toolkit. This is not a one-size-fits-all situation. An inodilator, like milrinone, is often your best friend because it helps the heart squeeze better and it opens up the pulmonary vessels. A real win-win. If you need a vasopressor, you have to be careful. Norepinephrine or phenylephrine can work, but you have to watch that PVR like a hawk. And you absolutely want the big guns available. Dedicated pulmonary vasodilators like inhaled nitric oxide. It's your secret weapon to directly target the lungs when they're the problem.
And listen, just because the surgery is over and the drapes are down does not mean you can relax. The post-operative period is just as dangerous. These patients do not go to a standard PACU. They need to go to an ICU or a high-dependency unit at the very least with nurses who know what they're looking at. The game isn't over until they are stable, breathing well, with a solid pain plan that doesn't compromise the respiratory drive.
So let's end with this final thought. The Fontan procedure has been so incredibly successful that 30-year survival is now common. These patients are living into middle age and beyond, and they're bringing a lifetime of complex, multi-system comorbidities with them to the OR. The question for all of us, as perioperative physicians, is this: how will we continue to adapt and refine our strategies to safely guide them through their entire, unique, lifelong physiological journey? It's a challenge that is only going to grow and one that we must be prepared to meet.